Thank you, Dr. Poon. Let me head up here. Can everyone hear me okay? Okay, great. So thank you, Dr. Poon, for the kind introduction. It gives me great pleasure to be here today, and I'm very honored that you're here to hear my talk that is part of a brain health series on cognitive functioning and aging. And so as Dr. Poon mentioned, I am a professor at University of Georgia.
Can you be louder, please?
Sure. Okay. So remind me, I am not very good with the microphone, and so if I need to elevate my voice or move this a little bit closer, please don't hesitate to stop me and ask me to speak louder. So as Dr. Poon mentioned, I am a professor at University of Georgia and also a licensed clinical psychologist. And I've been doing clinical assessments, diagnosis, treatment for over 20 years as a psychologist. My subspecialty is in health psychology and neuropsychology, and what that means is that how I conceptualize problems is from a biological, psychological, social, and cultural approach or perspective. And I use evaluations like neuropsychological evaluations to better understand the problems and to provide a more comprehensive evaluation of these challenges. So I'm currently part of the CARE team. And CARE team is the Cognitive Aging Research and Education Center at University of Georgia, which is part of the College of Public Health and the Institutes of Gerontology. And the CARE mission covers or conducts work in education, research, evaluation and diagnosis, and support and intervention. And so what I want to say is that how this is possible is because of those who have come before us. And so much of the work we're doing and we're able to do is because of the pioneers, the giants whose shoulders we stand on. And Dr. Poon is a giant in this field. And so I want to acknowledge Dr. Poon for all the work he's been doing and for making CARE Center possible at University of Georgia. So today I've been asked to talk about cognitive functioning, cognitive abilities, and how it's related to aging. So as we age, does our cognitive ability, are these changes that we're seeing as part of our cognitive skills, are these changes normal or not normal? And so what I hope to do by the end of my talk is to help you understand or to leave with an understanding of the differences between normal cognitive aging and cognitive aging related to Alzheimer's disease and other related dementias. So I wanted to start by talking about cognition, and what do I mean by cognition? So as a psychologist, we think of cognition as multiple functions. There's not just one cognition. There's multiple domains of cognitive functioning that we're evaluating, that we're observing, that we're watching. And so one type of cognition is perception, how we see and what we hear. Other types of cognitive function is attention, how well you're focused. You can focus on a specific task. And can you sustain that task over time? Can you maintain your focus on that task over time? Divided attention. Can you divide your attention, sort of be multitasking? So some of you might be multitasking right now, hearing me talk, and maybe checking your phone. So that is what divided attention. We also look at communication. So how well you can hold a conversation, track the content of the conversation, how well you can access vocabulary, looking at those kinds of communication skills. And memory is a big one. So we often think about, when we think about cognitive functioning, we look at memory. So components of memory, short-term memory, working memory, long-term memory, visual memory, and auditory memory. So all these are different components of memory. Short-term memory would be something like trying to remember what I'm talking about. So you're encoding some of this information in the short term. Working memory is being able to hold that information for a short term so that you can reason and think about what I'm sharing with you. Long-term memory is maybe 2 weeks from now, being able to encode what we're learning here at this talk and maybe remembering it and being able to pull it up maybe 2 weeks from now. Visual memory is obviously encoding memory that we see or things that we see, and auditory memory is things we hear. And finally, another component of cognition is reasoning, judgment, and problem solving. The point is that, I know this is a lot, but the point is that all these domains, all these functions are all part of cognition. So cognition is multiple functions. It is not just one function. Okay. Oh, before I go on further, I want to say also that I want this to be an engaging presentation. So please, don't worry about, if you have questions, feel free to ask them as I'm talking about this. You don't have to wait till the very end. Okay, so please, if you have questions, feel free to raise your hand and be happy to try to address those questions. But the point of this, again, is that cognitions are multiple domains that we're looking at. And so there are many factors that influence the cognitive changes that we experience as we age. And for example, our senses is one of them. So our senses, as we age, decline. It's just, part of aging is our senses decline, and in specifically vision. Our lenses lose elasticity, so we may have trouble focusing. Corneas become less transparent, so we may have problems with distortion and blurring. Our pupils dilate differently as we age, so we may lose ability to dilate more easily. Cataracts are a common event that happens as we age, and so cataracts can cloud the lens and decrease the amount of light that passes. Hearing can also affect and can also change. It also declines with age. Stiffening of the eardrums, shrinking of our ear muscles, loss of neurons in brain dedicated to hearing, and touch. Touch can also decline, also declines as we age, but also can affect our cognitive functioning. So loss of feel and touch receptors on the skin that reduces sensation, or reductions in the number of sensory fibers that stimulate the skin. So what I want to talk now about is the question that maybe you're all here about, is my cognitive functioning normal? So when I think of cognitive functioning, I think of it as being on a continuum, okay? So on this side of the continuum, we have what individuals would refer to as normal cognitive aging, right? So these are typical common changes that we have as we age. On the other end of continuum is more of an atypical type of cognitive changes. And so these are maybe less common, not normal. And so that's the continuum I want you to think about as I talk about cognitive changes that occur as we age. Any questions on this continuum before I move on? Okay. Now what I want to point out is that in between sort of normal cognitive aging and not normal cognitive aging or atypical aging, cognitive aging, we have what we call the gray area. And I'm going to spend a lot of time on the gray area, okay? Because this is where most of the questions happen. Is this normal or is this not, right? This is most of the things that bring folks to me. is what's going on, this gray area. So I'm going to spend some time talking more about that gray area. But let's talk about what would then be sort of typical, normal cognitive aging. So what kinds of cognitive changes occur as we age? So here are just some examples. We might see a decrease in our ability to pay attention. We might make a bad decision once in a while. We may have some problems with multitasking, so that divided attention that I was referring to. We may lose things from time to time, maybe miss a payment once in a while. Slower to find words, anomia. So that is also that tip of the tongue. And you'll probably see that in me today during my presentation. So this difficulty finding the word, right? So it's right there. I know what I want to say, but I can't quite pull that word out. So you might see some of that. That is quite normal. That happens when we age. And forgetting which day it is, but remembering it later. So these are kind of things, experiences that are very typical. In fact, some of these experiences aren't just associated with aging. You know, my son, who's 23 years old, I can tell you that he has several of these experiences. But the point I want to make about these kinds of experiences is, in general, there is no impairment, okay? So when you're thinking about these kinds of changes that are happening, one of the things that I would want to know as a psychologist is there impairment associated with it, right? Are you changing your routine? Are there things you could do before that you can't do now that is important to you, important for your level of independence? So impairment is so critical in evaluating some of these cognitive changes that you might be experiencing. Okay, so here we are at the gray area. So this is, again, if you remember, in this continuum, this is in between typical kinds of normal changes, cognitive changes, and atypical or not normal kinds of cognitive changes. And for folks experiencing this gray area, they might have more trouble remembering appointments, dates, events. You may start to have trouble finding your way around familiar environments. You might become more impulsive or show increasingly poor judgment. There's a subjective feeling of being overwhelmed more often. This feeling of being really irritable or short-fused, or feeling really stressed, okay? So what's associated with these kinds of experiences, one is distress, right? When you're having these experiences, you might have more distress, right? And stress. And we also see some impairment associated with these kinds of cognitive changes. That's what I'll say. I'll come back to this a little bit more. Any questions on the gray area?
When you say impairment, what do you mean by some impairment? Like, is that physical?
Yes, so I'm going to actually get to that slide about how we measure impairment. And so when I'm talking about impairment, I'm talking about some of the activities of daily living that we engage in. And I'll talk about that also instrumental activities of daily living. So things like doing laundry, you know, getting yourself from one place to another. Those impairments become more significant as we move further down in the continuum. But you might see some impairment. A lot of it is more around, in the gray area, is more around maybe remembering things. So here you might see somebody start using cues to remember appointments. Calendars may have somebody program something on their phone to remind them about certain kinds of events that they have to be in. So there is more reliance, right, on certain kinds of ways or mnemonics to remember these kinds of events and things that they have to do. So some impairment around that, but again, nothing significant. Because when it becomes significant, then we're talking about cognitive changes that are more atypical and not normal. And so usually at this continuum, family and friends really begin to notice this, right? So this is when you have family, they'll maybe start to express concerns about this, or you might express concerns about this with your family member. You'll start to observe feelings of your loved one maybe being more confused more often than usual. They might get lost or turned around more frequently. So these are, again, examples, right? They may repeat conversations repeatedly during a conversation. Difficulty managing daily tasks, so changes in their daily task. And also loss of interest in hobbies and usual activities. And when we're talking about significant impairment here, which I'm going to go right into soon here, we're talking about some kind of functional kinds of activities that we typically engage in that has changed prior to these kinds of experiences. So here's what I mean by impairment, more specifically. So we're talking about a change in your activities of daily living. So for example, hygiene, dressing, so more difficulty dressing oneself, eating, having difficulty feeding oneself, though not necessarily the capability of preparing food. Transferring and mobility, being able to stand from a sitting position or walking from one place to another independently. And we also look at, when we think about impairment, instrumental activities of daily living. So these are activities like shopping. Now again, we're talking about change, right? So change prior to these events and these cognitive changes. If there's a change in how you shop, if there's a change in your level of housework, if you were doing laundry before and you're not doing laundry anymore, washing dishes, keeping the house clean, managing your medications, having some difficulty managing your medications, taking it at the correct time, managing personal finances. Those are all areas where we would look to see if there is some level of impairment. And that enables us to determine some of these issues. Basic communication skills, having conversation, using your phone. Again, there's a change in how you use your phone. Transportation, driving oneself, arranging rides, or meal preparation. So these are all examples of areas where there could be impairment. And so ultimately, that information enables us to think clinically about what's going on. Okay, and so these are the different types of diagnoses that can be very helpful in better understanding some of the cognitive changes that might be experienced as we age. So many of us will be in this range, right? Many of us, this is the most common, these are all normal parts of aging. Some of us might, a smaller percentage, will have a diagnosis of mild or minor cognitive impairment. And this is the gray area that I was talking about. And as things get more severe, major cognitive impairment is sort of the next diagnosis. And by the time we get here, the underlying cause is likely to be a type of dementia-related disorder. Now I want to come back to here with mild cognitive impairment. Because if you see here, I have arrow that can proceed to major cognitive impairment. But we also have an arrow that says that if we identify this early and we understand the underlying cause, we might be able to reverse it, right? So some of the activities that Lisa brought up, diet, physical activity, certain kinds of brain nutrifying, supporting foods can really help reverse this type of impairment that some might be having. Now, when the impairment is associated predominantly with a memory problem, so if we're evaluating and we see that the dominant symptom that you might be having is memory related, then there is an increased risk that you will move on to more of a major cognitive impairment and a dementia-related disorder. But what I want to point out that here at this point, this is important for us to identify the underlying cause, because it could be depression. So a lot of the symptoms I talked about, motivation, problems with mood, energy levels, those types of impairment or those types of symptoms could be the underlying cause of minor or mild cognitive impairment, and that's treatable, right? So we can treat that. Thyroid disease could be the underlying cause. That can be treated. So there are many factors. This is such an important area to find out what's the underlying cause, because here we can intervene early. Any questions on this? Yes?
How rapidly, if one is diagnosed with minor cognitive impairment, how rapidly do you proceed to the age of cognitive? Is there considerable variation?
Yeah, so it depends how soon we catch this, right? And I'll show you a trajectory of memory and how we see memory can over time change when there is an underlying diagnosis of Alzheimer's. So I'll have a slide on that. But it really does depend on when this happens, right? And when we can catch it. So again, early detection, early identification is so critical. Okay, so here's my slide on memory, okay? So this is a slide that shows a graph of normal age-related memory loss. And below here, this is memory changes that occur as a result of Alzheimer's disease. Okay, so we're just taking one cognitive domain, memory, to look at how that changes over time. So here we have age in number of years, and on the y-ordinate we have memory. And as you see here, for the most part, there is a gradual decline of memory as we age, but it's very gradual, almost imperceptible. Okay, so you see this sort of steady decline. We'll talk about the different parts of memory that are associated with that decline. But it's declining, but it's a very slow, gradual decline. Now this is memory changes associated with Alzheimer's disease. And if you see, actually, it's comparable to normal age-related memory loss, right about the age of 50 years old. And then we see a slow, even more steeper decline, and then a really rapid decline as we move on to 80 plus years. And so what I want to point out with memory changes in Alzheimer's disease is that some of these symptoms are already beginning to appear at age 40. So these brain changes may begin decades before we start wondering what is going on, right? That gray area, what is going on? We actually start to maybe experience some of those changes early on. We think, oh, this is normal parts of aging. And then as we move further along the trajectory, we see that memory problems begin But again, day-to-day function is okay. So that is the gray area. That is the mild cognitive impairment that I've been talking about, right? So we might start to see some changes in our memory, but overall we're pretty independent and functional and doing the things to take care of ourselves. Eventually, with mild cognitive impairment, it starts to decline, and at this point on the trajectory, we see a diagnosis is made. So we're noticing problems, finally we say, and this is sort of later in the continuum. I'm sorry, I'm blocking you all, but later in that continuum, depending on when you are evaluated. So if you're evaluated here, you can see that there is a little bit more time before you move into major cognitive impairment. But if the diagnosis is much later, then we see a very steep decline, right? So once a diagnosis is made, function and memory rapidly decline, and the person has more difficulty functioning on their own. Yes?
How accurate are your diagnoses? Suppose you're tested at age 60 and have no sign of Alzheimer's. What lines can we place in that diagnosis?
So first of all, if you're tested at age 60 and there's no signs of Alzheimer's or other dementia-related disorders, then it's pretty accurate. Right? So that, part of the evaluation is assessing, sort of a knowing that we have changes in our cognitive functioning. And so if you're tested and you demonstrate no signs of cognitive functioning, then or cognitive decline, then that's a pretty accurate measure of your cognitive functioning. But I have to say that it's not that easy to make a diagnosis, right? So depending on where someone is in this trajectory, there are many things that are part of the diagnosis. So as a psychologist, I'm involved in the neuropsychological evaluation. And so I look at all those cognitive domains that I've talked about, and I assess each one. And I compare it to a normative sample of adults in your age range, and I can see to what extent you deviate from that normative sample. And based on that data, I can make some interpretation that your cognitive functioning is in line with your age group, or I might see that maybe you're one standard deviation below your age group, okay, or 2 standard deviations. So those are information that we start to look at to determine just how much your cognitive functioning is declining. The other thing we look at is impairment. So I show those activities of daily living, right? So we want to know what kinds of impairments you're having. And we're going to talk to your family. We're going to talk to your close friends, your loved ones, to be able to not only get your own subjective experience of it, but those who know you and their experience of those things. But I'm going to go into, actually it might be my next slide. No, it's not. But I will go more into sort of what we evaluate. And there's other factors. I talk about neuropsych evaluation because I'm a psychologist, but you'll also be meeting with a physician who will also run some tests. Question?
On your previous slide,
Uh-huh.
is mild cognitive impairment, is that always in the green, or can you have mild cognitive impairment that's in the green?
So by the time you can have some, no. So you're saying that the impairment itself or the symptoms. So you can have cognitive symptoms here, but right around here is where you start to notice symptoms that are changing how you do things. So you can think of that as impairments. Yes?
But if that happens, does that always mean you're on the lower can that happen and not continue to worsen, and you would still be?
Absolutely. Right, yes. So remember, what I said about mild cognitive impairment is that's just saying that we're seeing some impairment associated with the cognitive changes that you're undergoing, right? But we don't know the cause. And your medications could affect your cognitive functioning, right? Side effects from medications. Oftentimes I work with clients to talk about their medications and how it might be affecting their level of energy, their sleep, those kinds of important functions that affect our cognitive functioning, right? So part of my job, let's say if I was doing an evaluation, is when you're here, I want to better understand what's resulting in this. I won't just automatically assume that we're in the range of atypical, Alzheimer's spectrum diagnoses. And here we're going to try to understand what's going on. Yes.
To what extent is hereditary inherited if one or both parents had it?
Okay, so there's been a lot of work looking at genetics and predisposition, right, for Alzheimer's and other dementia-related disorders. And you may have heard of APOE4, whether you have one allele, two alleles. There's also APOE3. APOE2, so there's different genes that might predispose you. APOE4 is the most well-known gene that will predispose you or put you in increase. I think when you have two alleles of APOE4, your risk of developing Alzheimer's is 50%. Okay? Most of us have one or other types of APOE, right? So again, I want to talk about. I know we're sort of moving into the atypical, but most aging is associated with more typical or normal functioning. Okay, so most of us fall on this end of the continuum as we age. However, we obviously want to find out if somebody is at greater risk. And that way we can do early intervention, and we'll talk about early intervention in a few slides from now. Yes?
If you've got some, a higher level of dementia and Alzheimer's.
Okay, so dementia is the overarching category where Alzheimer's, Lewy body disease, vascular, frontotemporal, different kinds of dementias fall under dementia. Okay, so you can think of dementia as sort of being the big category, and Alzheimer's disease is the type of dementia. Is that, yes? You have a question?
Where does the word senility fit into that?
Well, the word senility actually comes from a gene associated with aging. We're dividing our task, our multitasking here. Okay, so I don't use the term because it's been used in a pejorative way. So I don't use the term, but it actually is derived from a gene that is associated with aging. Yes?
Speaking of that, how does one go about getting the DNA test to find out where you stand?
Oh, for the APOE4 gene? Okay, right. So yes, so if you are interested in being evaluated, you can go for genetic testing. So for example, if you have a family member that you suspect has passed away from Alzheimer's or other dementia-related disorder, you can request from your neurologist or from your primary care physician a genetic test for it. Yes? I know that, I can't think of anyone in town that does it, but I know Emory does testing. Because they have a whole institute also devoted to Alzheimer's and aging. So yes, you can get tested for whether you carry the alleles. So if you have, I think, okay, so if you have APOE for 2 alleles, you will have a 50% risk. If you have 1, it's 25% risk. And if you have none, it's like a 7% risk. Okay? But you can definitely be evaluated if you are interested in genetic testing to determine if you have the gene. And usually if you have a family member that has, has had the diagnosis, that's certainly one of the reasons that folks will want to get tested. Okay, great questions. Anything else before? Does that answer your question about testing? Okay.